All right. How you doing? Joshua Young's November 14th, Friday. Happy Friday. Happy Red Friday. I don't have any red on today, but I usually do. Remember every deployed. Thank you to all veterans out there. This is today's Medicare Minute for all people who are consumers and or eligible for Medicare. Again, we're in the throes of the Medicare annual enrollment period. And so really the main thrust of that is the ability to change your Medicare Advantage or your prescription drug coverage and what's going to start for January 1st. And so that's very clear. October 15th through December 7th is the time frame that you need to make this decision. I urge you to absolutely make sure that you've evaluated this stuff with a professional because it doesn't cost you anything to work with someone like us, me. Yeah. Okay, so number one, Medicare Advantage do certain things really well. Okay, certain things they do really well. Low to no premiums in a lot of situations. So zero premium often, and some really good plans this year even have a feature where it's even better than that. Okay, so there's even better than zero premium out there, which is crazy to think about if you think about it. Okay, extra benefits like ancillary benefits, which dental, vision, hearing, gym memberships. Some plans even have grocery and utilities and or rent assistance for more income sensitive populations. There are chronic and dual special needs plans. Chronic special needs plans are for folks with certain chronic health conditions, qualified chronic have to have a qualifying chronic health conditions. Okay, so there's a list of them that you can qualify for, certain plans for that. Also, Medicare, Medicaid plans, that's a dual eligible, DSNP for short. The government loves those acronyms, okay? Good doctor hospital networks. So typically you're going to be held to a network, but frankly, for most of these carriers, they've done a really good job in most areas. They're going to have a plan. There are certain rules that they have to follow from Center for Medicare and Medicaid Services, including how many doctors they have in a certain range. And if they don't have a certain number of doctors in a certain range, they either can't operate the plan or they have to allow people to have portability in and out of their network, even if it's an HMO. Okay, and so number two. The part no one explains. So the out-of-pocket expense. So we talk about the max out-of-pocket. Some people are concerned and they try to make a buying decision based off of comparing max out-of-pockets, which can come into play in certain situations if you don't set up your coverage correctly. However, most of the time, statistically speaking, and if you look at the math of it, it's reasonably difficult. You got to have a reasonably bad year to hit the max out-of-pocket normally, because most procedures listed in the summary of benefits are protected with a co-payment. A co-payment is a fixed cost. It's the same cost every single time. As long as you go to an in-network provider, you get the in-network copay. So that's the consistent cost where you run into problems and things that have a co-insurance. So a co-insurance is typically something like 80-20 in the Medicare world, 80% being paid by the insurance carrier or Medicare, and then the 20% being paid by you or another coverage if you protect yourself properly. Okay, so in a perfect world, we all want zero cost coverage and then zero cost if something happens. Reality is you got to have a little bit of cost or a little bit more cost in some situations to have less out of pocket if something happens. And there are situations where you can have no out of pocket if something happens. How you set things up is very important. Okay. Hospital stays can be hundreds per day. Now, it doesn't seem like a huge deal for a lot of folks, but if you're a typical average senior in America, you're living on 1,500 to 2,500, maybe 3,000, 3,500 at the most per month on Social Security. And if you have something else to supplement that, it's a bonus. But most, honestly, are living off of something like that. And so having a catastrophic event where you have hundreds of dollars due per day for 3 or 4 days or whatever the hospitalization is can be a financial problem. And so that's where you got to be aware. Hospitalization is typically a $200, $300, $400 a day or more or less, and then 1 to 5, 6, 7 days for copay, and then after that limitation of days, typically it goes to no copay for an unlimited amount of days for that hospital stay. But if you had multiple hospital stays in 1 year for different things, more than 30 days apart, you could incur the hospital copay multiple times in a year. So that is a way to hit your max out of pocket as well. Ambulance, ER, observation, this can all add up. And really in the ER, one of the problems can be, and in a lot of situations when they're doing a diagnosis, is all of the diagnostics. Sometimes the labs are relatively low cost typically. X-rays are typically not a terrible thing, but things like MRIs, CAT scans, ultrasounds, any of that advanced imaging diagnostic stuff can really be a higher out of pocket. So it's really important to understand where your exposure points are and how to mitigate against that. Okay, on an Advantage plan, also simple protection that works. You can pay you cash. Doesn't that sound? What if you got paid cash? to go to, I don't know, the hospital. Wouldn't that be a crazy thing? There is such a thing. It's called hospital indemnity insurance, which is designed in its formation when Medicare Advantage plans really came to be after drug plans came into effect in January of 2006. Really, hospital indemnity plans have been created to fill in the larger gaps of the Advantage plans. Not mitigate all of the risk, but mitigate the large chunks of the risk, the hospitalization, the surgery, the ambulance, the emergency room, the skilled nursing, the physical therapy. So these are all things that happen if you have an event. You could have an involvement of some or all of those copays, and having an additional coverage to protect yourself against that. My mom has it. Lots of my clients have it. It's really, really smart if you can afford it to put it into your coverage portfolio, because if the worst case scenario happens and you're on a fixed income, having as minimal disruption to your normal budget as possible is very key to not only being mentally healthy and financially healthy, but it helps you recover faster if you're not worried about the cost. Okay. And so if you don't know what hospital indemnity is, you got to talk to someone like us. There's also cancer, heart attack, and stroke, which fills in gaps there. So there are some gaps within coverages, and this goes for Medicare supplement too. If you have a Plan G or a Plan F, even if you have a Plan F, there are still holes and gaps in your coverage, and you want to protect yourself against those. Okay, and most of it comes on the Medicare sup side, on the prescription drug side, frankly. But it depends on which plan you have, and you could have more exposure than you think. Okay, why this matters? The add-ons, okay, the add-ons. You don't go with Medicare A and B without getting a Medicare supplement or Medigap. It's very, very unintelligent to do that. Same thing with Medicare Advantage. If you have the budget for it, and typically you should have the budget for it, if you buy it at the right time, it should be less than $100 a month. And in a scenario like that, then you're looking at coverage that's going to fill in the gaps for you.